Overview and Scrutiny Committee. May I remind members that the meeting will be recorded for subsequent broadcast via the Council Meetings YouTube site, and that members of the press public may record and take photographs, except where there are confidential or exempt items. Can I remind officers and guests joining on Teams to please keep cameras and microphones off unless speaking, and please use the raise hand button if they want to speak. For officers and guests in the room, please speak directly into the microphones to ensure that the live streaming is clearly audible. Apologies. Can I ask members and scrutiny officers if there have been any apologies received for the meeting? Jane Jones, yeah. Thank you. Declaration of interest. Can I ask members if they have any declarations of interest to make? Councillor Moore.
Thank you, Chair. Just to make people aware that I'm a trustee of Birmingham LGBT, which holds a contract with UHB and Umbrella, and the charities referenced in the report, and also I'm a trustee of Birmingham City Lice, which has a contract with the ICA.
Small. I've got action notes and matters arising. I've got two notes to flag up. First of which is from the 22nd of November meeting from Substance Misuse, Birmingham Adult Treatment Services. They were going to provide us with information on the association between people living in HMOs and exempt accommodation and in treatment for drug and alcohol abuse on a ward-by-ward basis, and to provide information regarding the training that has been given to housing providers. And my understanding is that CGL's information was circulated to members by email on the 31st of January. Has everybody received that? As far as we're aware. Okay, if we can check, and if we do need it resent, then let me know. The second item concerns the approved mental health profession. We've had a statement from them, I shall read out, and if people don't necessarily catch all of it, I can arrange for Gail to send it out by email to people. And this was regarding on how many occasions people have been refused to admission to hospital from a private provider. And the statement we received says, I am unable to provide an accurate figure, just anecdotal evidence, not retained, as to how many reasons why someone is declined admission once their application has been made. I am aware of 2 occasions within the last 12 months, and these were for children under age 17, based on presentation with the admitting hospital stating that they were unable to accommodate due to the complexity of the needs presentation on arrival. And the second point is that a copy of the latest HMHP annual report was circulated by email to members again on the 31st of January. Members that haven't got that, you'll let us know. We can get Gail to resubmit it to people. And I said, if people want an actual copy of this brief statement, let me or Gail know. We'll get one actually sent out. Okay, we've got 2 presentations today. The first of which is by the Birmingham Sexual Health Services umbrella from UHB. We have 60 minutes in total for this item, so could we please potentially keep presentations to about 20 minutes? And allow for questions from members of the public. We've got Carl Bees, who's the Commissioning Manager for Adult Public Health Services, and his team. What I'm going to ask people to do is possibly individually introduce yourselves rather than me giving everybody's name and we're not quite sure what I'm referring to. So if I could pass it over to you, Carl, to take that forward.
Yeah, thank you, Councillor Brown. Good morning, everybody. My name's Carl Bees, and myself and my colleagues from Birmingham City Council and Umbrella are here today to update you on sexual health treatment and prevention services in Birmingham. And that service is delivered by our Umbrella service, which is delivered by University Hospitals Birmingham. As part of our submissions to the committee, we've provided sexual and reproductive health contextual data taken from the OHID, Office for Health Inequalities and Disparities Fingertips website, summary profile of local authority sexual health, which is the Splash report, and our financial spend since contract commencement in 2015. And our Umbrella colleagues have also provided a summary report which covers their contractual year, which is the 1st of August 2021 to the 31st of July 2022. So my colleagues with me today are Becky Pollard, who's the Interim Assistant Director in Public Health for Adults and Older People, Juliet Granger, who's the Public Health Service Lead for adults. And to my left is Maureen Black, who is the Umbrella General Manager, and Meg Boothby, who is the Clinical Lead Umbrella and Consultant in Sexual Health and HIV Medicine. So in terms of our presentation, I'll deliver slides 2 to 6. Colleague Juliet will deliver slides 7 to 10, and then Maureen will deliver the Umbrella presentation. So, to give an overview of the Umbrella Sexual Health Service, it's jointly commissioned with Solihull Metropolitan Borough Council, so that matches the integrated care system for the city, that's Birmingham and Solihull, and that's been in place since the 10th of August 2015. There's been a recent contract extension to the 31st of March 2024. That was due to the impact of initial constraints of the COVID-19 pandemic and anticipation of the new sexual health policy and national service specification alongside commissioning and procurement guidance. The contract extension period is to provide ourselves as commissioners with the necessary time in order to ratify the draft sexual health strategy 2023 to 2030 for the city and use public consultation findings in order to inform our commissioning and procurement process in order for the new service to commence on the 1st of April 2024. I've provided details of the contract value since the contract commenced in August 2015, and the current annual block contract value is just over £14 million a year. And inflationary uplift for the next financial year, 2023-24, is still being discussed with our colleagues at Umbrella and is still to be agreed. Core city cost comparison. This is for the year 2021-22. And we put this in because if we just give you figures on their own without any context, it might be, oh, well, how does Birmingham compare to other cities, what we spend, etc. So we do this by spend per head of population using the latest census data. And I'll put a note in there that the core cities are Birmingham, Bristol, Leeds, etc., just so you're aware of who those core cities are. And they're basically the biggest countries in the city, and they'll have a similar breakdown to Birmingham in terms of population, etc. And the data source is the local authority revenue outturns, which are the latest available for 2021-22. So the highest spend was Newcastle, £18.42 per head of population. Birmingham's got the 6th highest spend with £14.38. So we're roughly in the middle of the pack. And the lowest spend, Bristol, which is £9.87. And there's a mean value of £13.30. So we're just above the average value in terms of the average cost in terms of cost per head of population. Just in terms of what the requirements of the service are, it's a statutory service mandated to commission open access sexual health services, sexually transmitted infections, STI testing and treatment, and advice and access to a broad range of contraception and preventing unplanned pregnancies. Then there's the public health outcomes framework and locally agreed outcomes, which are increasing the use of good quality contraception in order to reduce under 18 conceptions and abortions for all age groups, reducing the late diagnosis of HIV and the transmission of sexually transmitted infections and bloodborne viruses such as hepatitis B, hepatitis C and TB. And to prevent reinfection by ensuring prompt access in order to get early diagnosis and treatment. Provide better access to service for high-risk priority groups. Improve support for people vulnerable to and victims of sexual coercion, sexual violence and exploitation. And to increase the chlamydia screening diagnostic rate in the 15 to 24 age group. In terms of the public health outcomes framework performance in 2022, and I'll put 2022, but some of the dates, depending when we get data, we might have a year or a 2-year lag behind. So in terms of reducing underage conceptions, that rate per 1,000 women aged 15 to 17 continues to decline in line with the rest of the country. And in 2020, the rate in Birmingham was 16.1 per thousand compared to 13 for England and slightly above the West Midlands rate of 15.1. Long-acting reversible contraception, which is LARC, and this is 2020, the total prescribed per 1,000 women aged 15 to 44 was 26.5, below the rates for England of 34.6 and 27.3 for the West Midlands. And I will cover this in a future slide, but it must be noted because that's 2020, that was the height of the COVID pandemic. And our colleagues at Umbrella will touch on that our focus during that time was open access treatment for those that were symptomatic with anything related to their sexual health, where long-acting reversible contraception obviously is not going to be displaying symptoms. You just want to be having the option to have that long-acting reversible contraception, whatever form that may take. Reducing the late diagnosis of HIV. And again, the latest figures of 2019 to 2021. Birmingham figure was 43%, which is comparable to the England average of 43.4 and the West Midlands average of 42.8. And new STI diagnoses, 454 all new STI diagnoses per 100,000 of the population. Again, very similar to the England rate of 551. But higher than the West Midlands average of 429. And just one final point on that performance was increasing diagnosis in terms of chlamydia in 15 to 24-year-olds. Our rate in 2021 was 1,032 per 100,000 people, compared to 1,334 in England, slightly below the West Midlands average. But again, as I mentioned with LARC, because that's 2021, we were still experiencing some of the knock-on and the after effects from the pandemic. In terms of the Public Health Outcomes Framework performance, this is our comparison to core cities. Reducing under 18 conceptions, 2020, we ranked 4th out of the 8. Prescribing LARC, we were 7th, but again, I've touched on that because those figures are 2020 and the issues with COVID, our latest figures that probably won't be published for another 6 months or so show that has increased, and our colleagues at Umbrella will touch on that. Reducing the late diagnosis of HIV, we ranked 5th, so we're middle of the group, along with STI diagnoses. And increasing chlamydia, we ranked 8th, but again, 2021, and I've put a note at the bottom, Umbrella are undertaking a citywide chlamydia campaign during this month to improve testing rates, promoting STI home testing by ordering free STI kits online from the Umbrella website, utilising 154 Umbrella pharmacies across the city that are signed up to the sexual health service, and also fully utilising social media in terms of targeting the younger population. I'll now pass you over to my colleague Juliet.
So the next couple of slides are just to give a bit of an overview about some of the aligned work that we're doing that sits alongside the main sexual health service contract. So talking more about the kind of system around sexual health. So last October, Birmingham signed up to become a fast track cities city. And that is to contribute to the UN AIDS target. So there are cities all across the world that have signed a declaration to reduce the prevalence of AIDS around the world. So we've signed up to a 95, 95, 95 target. And what that means is we're working to make sure that 95% of people with HIV are diagnosed, 95 are then on treatment, and 95 then have that virus suppressed to an undetectable level, which means that the HIV can't be transmitted to anybody else. So those are our targets. Birmingham is doing particularly well against those at the moment, but we've got some key issues in making sure we are diagnosing people with HIV early. So those are some of the kind of focuses around the HIV programme that we need to take forwards. In Birmingham, as well as HIV, we've also included viral hepatitis and TB within our programme. So we're quite pioneering in that we're one of the first cities to have added to the HIV targets. And we are looking also to eradicate hepatitis B, C and TB by the kind of World Health Organization timelines for 2035. We have started to develop a draft action plan that was published when we had the launch event back in October. And that is the contributing factors to those are the needs assessment and the consultations that we did over the period of a year prior to the launch ceremony. So we really understand the demographics of the population and the needs in terms of those diseases. The initiative effectiveness is going to be monitored in terms of the targets that we need to achieve nationally and globally. And there is a steering group and a project board that oversees that work. The Fast Track City Action Plan will also form part of the sexual health specification going forwards in terms of what we want to achieve around the bloodborne virus additional activity. So coming on to procurement then, as Carl mentioned, we've got a contract extension in place with UHB and Umbrella Services until 2024. There's been a considerable amount of work done in terms of a needs assessment to look at population needs over the last few years since the service has been operating. And then a consultation with the public and professionals last year on the draft sexual health strategy to inform the work that we need to do going forwards and up until 2030. That feedback went to Health and Wellbeing Board last September, and we are just about to publish the new sexual health strategy, hopefully next week, in terms of informing the kind of direction of travel around the work we want to do with the new service specification. As Carl's also mentioned, we'll be jointly commissioning again with Sandwell Metropolitan Council and also the new integrated care system in terms of some of the added value that we want to develop around primary care systems and all of the changes that are happening with the NHS. The sexual health service is potentially an all-age service, although for under 13s, obviously, there are significant safeguarding elements to providing sexual health care to under 13s who are under the age of consent. So there's an additional piece of work there to look at working with the SARCs and looking to work with paediatric teams as well around that age group. Also working with UHB and the Umbrella Service on some quality improvements. I've just taken you through some of the performance. So we're particularly working around access to long-acting reversible contraception in Birmingham, looking at all the touch points for people, for women particularly, in terms of where we might encourage take-up of long-acting reversible contraception with our GP colleagues to expand the coverage in primary care as well. This work stream is around pre-exposure prophylaxis or PrEP. And that is the medication that people with HIV take to suppress their viral load. So we're looking at the take-up of that service and how we can increase awareness to the populations that are most at risk in terms of the service offer that we've got there. And then the third piece of work around pathway improvement is business continuity. So building on lessons learned from COVID-19 pandemic, around how we kind of sustainably deliver those services going forward into the future. And then the final update that I wanted to kind of provide to the committee was around MPOX. Obviously, last year we did some considerable work in terms of the virus outbreak in the UK. But there were just under 3,500 confirmed cases in England, with 64 cases in Birmingham. Predominantly, Umbrella UHB were the front line in terms of not just Birmingham, but the regional response to that in terms of vaccination and follow-up. So just under 1,500 vaccinations provided through Umbrella. Since January, we've had no new cases confirmed, but opportunistic testing of vaccinations is still continuing. In terms of cost of providing that additional service, so the vaccine charges were reimbursable, but the staffing and the resources that were deployed to support that were entirely from UHB and Umbrella as well. So there are some payoffs in terms of the kind of delivery of services, as we know, when kind of pandemics, we're responding to pandemics.
Juliet, I'll just get the presentation up for our.
Doing that, can I just make a quick point of clarity? I think you said Sandwell, but instead of Solihull, so it'd be co-commissioning with Solihull, Metropolitan.
We are.
Yeah,
Apologies,
that's right,
yeah.
that's fine. And the other was just around the PrEP, that it's the medication that is used for people who are HIV positive. However, in the context of PrEP, it's taken by people who are HIV negative in order to reduce their risk of acquiring HIV infection. So it was just scrambled words. That's right, that's a problem.
Okay. Good morning, everyone. My name is Maureen Black, and I'm the General Manager for Umbrella Sexual Health. So I am just going to start my presentation by giving you some context. So whilst this presentation is covering the period from the 1st of August 2021 to the end of July 2022, I think it's important just to take a step back and look at the pledge that Umbrella Sexual Health made when we were first awarded the tender in 2015. So at that point, prior to that, Umbrella's sexual health services were very fragmented. They were clinically based and they weren't predominantly focused within the community. So the model that Umbrella brought into place was to ensure that it was community focused, and that was critical to us in terms of working with our pharmacies and our GPs and our delivery partners. And with education, it being underpinned by education at the core, we also developed a walk-in service. We expanded the sexual health geographic footprint with our satellite clinics across Birmingham and Solihull, all of which was very successful. We were able to deliver around 100,000 contacts per year. So that's just to give. Now moving fast forward, we're in a new landscape at the moment, and that's been totally realigned by COVID. So our focus throughout the past 12 months has been to look at how we can recover our service to pre-COVID activity. We recognise that it's not going to be a complete replication of where we were in 2019, because obviously the landscape has changed, and we recognise that also there are other ways that we can deliver the services, mainly through digital enhancements. And I think the fact that all services were able to step up so quickly throughout COVID is an indication of how much we can actually look at services being delivered in a new way. So for the past 12 months, we have focused on recovering our service, looking at the activity that we have now in contrast to the activity in 2019, and most importantly, supporting our staff well-being, because so many of our staff actually were on the front line supporting the ITU and the wards throughout COVID. And naturally, that had a huge impact. So it isn't just about recovering the activity, it's actually around building the resilience within our staff. And we've been able to do that by encouraging resilience training, staff engagement sessions as well. You mentioned the partners. Our partners are critical to delivering our service. They're very close to those on the ground that maybe we don't have the same contact with. So that's very important to make sure that we enhance that relationship. And we've been able to do that as well throughout the past 12 months with our GPs and our pharmacies and our young people services by having forums and maintaining that contact. So that's the landscape throughout the past 12 months. So we mentioned getting back to the pre-COVID activity. I'm confident and I'm very happy at the fact that we are moving in the right direction. So this is just some figures. I won't read through all of them, but if I can just highlight the ones that I think are particularly significant. All of these figures demonstrate an improvement and an increase from where we were the previous year. So, for example, we had 83,670 clinic attendances within the period. It's a significant number, and it's a 14% increase from the same period last year. We delivered 55,000, just over 55,000 self-testing kits. That demonstrated a 26% increase. 51,964 all-age contraceptives, 31% increase, and 3,661 18 and under contraceptives, demonstrating a 23% increase. Across all of our clinical service and our GP and pharmacy, we were able to deliver, not with our pharmacy, with our GPs and our clinical service, we were able to deliver 9,636 LARC fit-ins, and that showed an increase of 11%. We delivered 23,209 chlamydia screenings for the age groups 15 to 24, showing a 44% increase. We tested 38,193 HIV tests, showing a 58% increase. We were able to meet our target and deliver 913 new patients onto PrEP, and that was a 17% increase. So we still continue with our umbrella campaigns, and in terms of accessing our service through digital enhancement, we have launched a chat health service in November, 2022, and that is a safe digital tool that allows patients 18 and under, in fact, all patients, to contact our healthcare professionals via text and receive a response. With the launch, we've had 1,000 patients contacting us, and we continue to do well on our umbrella website. In terms of response, we were able to respond at pace to the monkeypox virus. We delivered 597 vaccines and undertook 130 tests, and we continue to do opportunistic testing. Those numbers decreased significantly, but the option and the testing still remain. So I mentioned our umbrella partners. They are critical to the service, to the wide reach of the service, and all of our partners have contributed significantly throughout the period of COVID, in the sense that even if they couldn't have face-to-face interactions, they still kept contact with us. So Birmingham Youth Service for the period, this period is the past 12 months, we're able to deliver almost 11,000 clinical interventions. Our BLGBT partners delivered just over 5,000. Birmingham Solihull Women's Aid had 291 contacts, and our Rape and Sexual Violence Project, RSPP, had 3,818 contacts. Our theatre group that we work with for young people, Loudmouth, delivered 139 group sessions, and that equated to 17,281 attendees. Across all of our services, we delivered 6,431 long-acting reversible contraception, LARCs, and 57,631 pharmacy contacts, which showed a 28% increase. So I think the point of all of these numbers is that they do reflect that we're absolutely moving in the right direction, and we are confident that we will be able to get our service back to pre-COVID levels. So where are we now? We have a new landscape for 2023. We've taken a lot of learning from COVID. One of the main learning points that we've been able to glean is the fact the using digital enhancement has been critical in enabling access and expanding access. So we will continue to look at new ways of delivering sexual health services. And as I mentioned in my previous slide, Chat Health has been very, very instrumental in allowing that to happen. We'll be working with our commissioning colleagues to improve our LARC uptake within clinics. And I think Carl has mentioned the fact that the drop in LARC was more significant than our GU activity, mainly because we were actually focusing on symptomatic patients as being those that we needed to see during the COVID pandemic. So we'll be strengthening access, and one area that we're particularly looking forward to developing is our young persons one-stop clinic at Boots City Centre. So that will include a seamless service that will allow young people to have STI testing, contraception, and sexual health counselling. So it'll be a one-stop clinic for all of those sexual health needs. Continue to work with our partners and develop new partnerships. I'm pleased to say that we're already in the process of working with the BID, the Birmingham Institute for the Deaf, and also Solihull, Birmingham Solihull Mental Health Trust. We will also ensure that all of our service aligns itself to evidence-based research. We have a very robust research department. From that will inform our services as well as we move forward. I mentioned access, so I know that there has now been a focus on older people who are presenting with sexually transmitted diseases, and we're focusing on that particular cohort of people within our campaign structure. So in May this year, we have a campaign that's targeted purely towards the 40+ age group, and that will be over a 4-week period. So all of the above is where we want to be moving forward, and of course all of that will be underpinned and aligned by the sexual health strategy. So in conclusion, we see ourselves as a very adaptive and flexible service. We will take the learning that has emerged from the COVID pandemic. We'll work closely with our partners on the quality and improvement areas, and we will continue to be flexible in the main for all of our patients that come through the front door and the access.
Can I finish the presentation now, Carl? Yep. Okay, thank you for the presentation. I think it's been a really useful one. Members' questions. Councillor Pocock.
Thanks, Chair. Yes, my main focus is going to be on the Commissioner's slides. Just for clarification, really. The funding, this is directly from Birmingham and Solihull. Does this come out of the public health grant? It's a ring fence.
It is a ring fence grant, yes, that we receive yearly. Yes.
Anywhere else, it just comes out of that fund.
It just comes in other areas such as substance use. There is additional funding from the Office for Health Inequalities and Disparities, but in terms of sexual health, that's the only funding. Apart from Fast Track Cities, there's been a little bit of funding available for that, hasn't there?
Yeah, there was additional funding made available for HIV, although that's been now subsumed within the main grant. There are services, though, that are commissioned by NHS England that wrap around the system, but yes, the public health grant funds the core service.
Look at your trend data in the separate set of slides. In real terms, this is a decline. Is this because the public health grant has reduced over that period of time?
The public health grant has increased slightly. We're still waiting to hear what the grant will be for 2023-24. It's been increasing very slightly. Becky, you might know a little bit better. It's been about 1 or 2%, hasn't it? It's been going up, so below inflation. But I think in terms of the performance, and we touched on it, Councillor Pocock and Maureen, I think some of our figures when they're 2020, it's still part of that COVID response, and based on the figures Maureen gave in terms of increasing the number of clinic attendances, that's increased by 40%. It's all going up exponentially. So we would hope that this time next year, that in terms of our performance, we have got, in terms of LARC and chlamydia especially, that we're back up to those pre-COVID levels and performing well against our core city colleagues.
Down to the last two questions I'm just trying to understand these figures that you presented us, comparisons with the 8 core cities. With 6 out of 8 in terms of the average spend, so obviously the bottom half, and yet we spend above the mean value. Now, how can we spend more than the average if we're 3/4 of the way down the league table, as it were?
It's a very rough guide to give you some, just to give you some, I suppose, benchmarking as towards what we spend compared to other local authorities. And yes, our mean average is slightly below where we are on performance. You'd think if we were closer to that mean average of £13 and whatever it worked out to, you think we might be a little bit higher. But I think when we come to this time next year, and when we've seen the improvements that we've all outlined, we'd expect us to sort of be more on par with it.
I think I'm right reading your table correctly. We're spending more than the average.
Yeah, we are.
14, but we're
But then we hopefully will have better outcomes for that spend.
focusing on the figures. We're spending more than average, and yet we're in the bottom 3. I just couldn't work out how you could be more than average and yet in the bottom half of the table. Perhaps that's something that could be clarified later. And also, finally, then on the core city comparisons, you've made a sort of the point about COVID causing us to drop in the league table. But cities had COVID, and some cities, I think, worse than ours. So why are we using COVID as a reason for not being as high in the ranking as other cities when the other cities have got the same problem? I don't see COVID as the explanation for any of that comparatively poor performance.
Can I jump in? Is that right? So I think, yes, obviously the whole country was affected by COVID. Birmingham was particularly affected, and UHB was one of the hardest hit trusts in the country in terms of the amount of COVID activity that came through. And Umbrella being part of UHB, actually we were pulled in to support the COVID activity, which I think wasn't the case in a number of other sexual health services around the country because they sit outside the acute trust. So I think there wasn't an impact there. So it was around that. So also I think Birmingham was particularly hit, and I think the way Birmingham was hit in terms of the demographic and the way it affected the population in terms of kind of stopping people accessing services was particularly significant. We also had a slightly odd situation in the fact that pre-COVID we had been incredibly successful in our online offer and our online STI testing services and that kind of thing. The rest of the country rapidly caught up during COVID, whereas we were already kind of at capacity in terms of the amount of online that we were offering. So I think when other services had to shut their physical front doors, they were able to replace that with online activity. We already had the online activity and the physical front door. So when we shut the front doors, we didn't necessarily have the capacity to use that additional activity. So I think there was a number of things which kind of around COVID that kind of led to things being slightly different in Birmingham than they were in other centres.
I can understand that in terms of the way that your organisation provides the service. That's what there is. I might dispute the question about cities. We're talking to Newcastle, Manchester, Sheffield. I'm pretty sure they were pretty much on the level of Birmingham, but I can understand that the way that you provide the service required you to be diverted to other activities. I can see that point. Thanks, Chair. Maybe we could just come back to some other points and maybe after the meeting to clarify why we spend more than the average and yet are at the lower part of the league table. I suspect there may be some further work to be done on statistics is my guess. Thanks, Chair.
Thank you, Chair. I've also got 3 questions. The first one's around the text messaging service. Currently it's experiencing technical issues and there was no mention of that. So how long has that been ongoing and when's that going to be addressed? Because given that's how results are communicated, rather worrying that your text messaging system is down or certainly it's experiencing technical issues. Obviously, to use digital more. Does that include the website and how home testing kits are ordered? Because at the moment it's 7 pages, which seems very, very clunky to order a test kit when you compare it to other digital platforms. Amazon is seamless, but for some reason to order a home testing kit, you've got to go through all these hoops to get one. And a lot of the information is, every time you order one, it's going to be the same. So is there not? Appreciate not everyone will want their information saved, but on a lot of websites you can save your information, like name, address, etc., so that those who are happy for information to be shared, to make it easier for them to order, particularly those who regularly order home testing kits, those who take their sexual health seriously and order it on a regular basis, that would make that system much easier. So that's something that's being considered or could be factored in. Then my final question is around on the website, when you order a home testing kit, there's, I don't know what it says, there's an option around, there's various questions with statements you have to tick, all to do with MSM. And no matter which one you click, and except the one, none of them apply, it then recommends you have to go into a clinic. But all those around MSM, none of them are to do with men who have sex with women, which I find strange, given that there are high risks with that too. And someone who has sex with a man once and it be protected will be told to come to a clinic, whereas a heterosexual man who has unprotected sex with lots of women wouldn't be asked to come into a clinic and instead could have a home testing kit. So that seems to be a real loophole in that, and I don't understand why all those questions, and I get that they're all targeted to men regardless, and I can understand that, and some of those do have high risk associated with them, but there are high risks also associated with heterosexual men, but for some reason there are no questions regarding that.
I'm happy to take the first one. Yeah, okay.
So in terms of the text messaging, we did have an issue with some of the text messaging that wasn't actually being, without going into too much of the technical detail, but our text messages go through NHS Digital, and there was a problem with the quarantining of text messages that they actually were doing, and we picked that up ourselves. Now, we've immediately put mitigations in place, and that's been very, very robustly managed. We also reported it to our trust, and as a clinical incident, we have Datexes, so it went through that. We reported it to our executive team, and we've had a serious incident review of that. So not only did we immediately put mitigations in place, but we also made sure that there was a robust governance risk assessment of that by the trust, and that's ongoing at this moment. So I'm very confident that that situation is being dealt with. Do you want to pick up on the other two issues?
Yeah, so the second
website.
one, which was around the streamlining of the website. So yes, that comes back again to what I mentioned earlier. We were very early adopters of the online testing system, and we do it entirely in-house. So basically, the online ordering of the testing, the sending out of the tests, and the analysing are all within UHB control and within the labs. And that way, when someone orders an online testing kit from us, their results are treated exactly as they would be for someone who attends the physical service. So there's absolutely no differentiation. Because of that, our IT is not necessarily as advanced as those people who use a commercial provider of the online STI testing, whereby they are purely set up to deliver a paid for online testing service, which sits separately to the sexual health service. So as one of the improvements in the business continuity that we talked about, we are very much looking at improving that digital platform. And when it was set up, we had a separate test. So I'm not a technical person, but the bit of the website where you order the test is slightly separate to the website itself, because one was set up by IT, the other by Webmaster Etc. We're looking to try and integrate those for the very reason that you said, that we can then look to see whether we can get some sort of user accounts, which might not only allow people to track their testing, you know, you've ordered a test, where is it, etc., when's it in the process. So that's something we're aware of, that we started off ahead of the field because everyone's kind of, particularly in the last couple of years, been pushed further forward. We now need to catch up and make sure that we're providing we retain the benefits of the way we provide the service, which is it being fully integrated, but by also then get the advantages of a more commercial looking platform. So that's something we're aware of, and yes, something that we're working on. The second bit about the ordering the kits and why we direct people to clinics. So that's primarily because there are services that we believe people who answer those questions would require or should be offered, which we cannot offer in an online situation. So, for example, access to hepatitis B vaccination, access to PrEP and discussions around that. So that's why the questions there are targeted in that way. I would have to go back and check, but I do believe that there are, so if you answer certain questions, I think it's around number of partners, whether you're heterosexual or MSM, you would still be advised to attend. Is that not the case?
It only asks about sexual partners if they're with men.
Right, okay, so it doesn't ask that. So that's slightly different to what we would do in the clinic, where we would, you know, offer that vaccination, you know, regardless of sexuality in terms of number of partners. So that's something that certainly, yes, well picked up and we can go back and look at. But generally speaking, when we were setting up the service, it was around, we wanted to make sure that people didn't miss out on the wider holistic services because they were accessing services online, but we also didn't want to deny people the service. So we never say someone can't order a testing kit. We just say that we would advise, that you attend the service, and that the reason for that is we believe there are other services that they would then be offered that they wouldn't be able to access purely just through the SDI.
Very valuable feedback. Thank you.
About the LARC services, and particularly, I may have missed it, but I don't seem to have much information, kind of waiting times or length of time between when somebody's kind of requesting and when they'll get an appointment to actually have it. So how long will that take normally, and how long do people normally expect to wait between when they first kind of turn up and when they actually get the service? And how's that compare?
So around 4 weeks is what we're saying, but the way we work the system, because we have our GP partners who also provide LARCs, we don't currently have a integrated booking system. So if someone approaches Umbrella, we can't book them into a GP appointment. So what we tend to do is we will tell people when our next appointment is in Umbrella in terms of the waiting time, but also give them the information about the GPs in their area, a number of which also will see unregistered patients, so they can see any Umbrella GP and let them know that they can approach those services to see if they have a sooner appointment, and if not, then obviously to come back to us. So although there's a wait time, within the clinic, there's also capacity within the wider system which people can, access if that's what they want to do.
How does that compare to other areas? And of course, is that wait time, is that kind of?
Well, our contracts team monitor the waiting time for our GP partners. And if there's any GPs that are over like 18 days, they will contact them immediately and say, have you got any capacity problems? Do you have complex patients that you're concerned about that need to be seen more quickly? And if that is the case, they would contact us and we would have a conversation. Our RSH consultant would have a conversation. But actually, we've done that, and most of our Umbrella GP partners have said no. It's fine. We're managing okay, and if we weren't, we'd come back to you. I think quite a lot of the patients that will go to their GPs are used to going there, and the GPs potentially are used to them, so they're quite happy to go back to the same place.
In terms of comparisons with courses, I'm afraid I don't have that figure. In terms of the region, we know through the fact that patients outside of Birmingham Solihull area, frequently contact us, that actually our access is certainly comparable, if not better, to other close by areas, because we have Asbury patients wanting to use our services, which we're not always able to.
And going forward, is that time, that 4 weeks, something you're looking at reducing, or are you kind of happy with that as a kind of the time that people have to wait? Or
so in terms of the work we're doing, certainly increasing the capacity within the clinics is something that we are actively doing, and so that will by definition hopefully reduce that waiting time. It's obviously important to note as well that if a patient contacts us wanting a LARC, that they would have had a consultation. They wouldn't have just been told to go away for 4 weeks. So they would have had the full consultation, counselling around the procedure, and would have been to make sure that they remain protected until they are able to access that procedure. So it's not about kind of go away for 4 weeks, come back and we'll talk to you about it then. They get their initial consultation there and then. It's just the actual booking of the procedure, which they may have to wait for, but they will have been given, the appropriate information and bridging to last until that procedure is available.
Thank you. Years ago, I was a non-exec of a trust that had responsibility for Whitwell Street. One of the problems that we found was that because of the embarrassment of sexual health problems, shall we say, that there was a lot of out of area contact. Now, is that monitored?
Yeah.
People are very, very crafty, and will give a friend's address in Birmingham to try and hide their embarrassment and not be traced back. And I wondered whether this was still prevalent, and it could actually, if you go back to the Councillor Pocock's question, start to appreciate perhaps if that is an underlying problem, why, when we look at the figures, Birmingham spend is so low. Because if you've got an average impact with higher intensity usage, it's going to reduce your average spend, isn't it?
Yeah, I can pick up a little bit on that, Councillor Tilsley, and then Megan Moore, feel free to come in. We since the start of the contract, we've monitored our out of area uptake of the service, because Birmingham, probably a little bit less now because of COVID and less people coming into the city centre. As you can see, when you come in, it's a lot quieter than it used to be. As a rule of thumb, out of the service as a whole, 80% of the clients are from Birmingham, 10% are from Solihull, and 10% are from out of area, which is probably a little bit higher than our regional, our local colleagues saying Sandwell or Dudley, because if people are travelling into Birmingham for work, it might be easy to access. We've got more clinics and better coverage in terms of our pharmacies, our GPs, the clinics across the city. But in terms of anyone coming in from out of area, say, for example, Coventry, if they come in, if they receive, because it's an open access service, regardless of where you live, be it Scotland, Wales, anyone could access that service, but then Birmingham City Council recharge that local authority for the activity, so that money is clawed back. And alternatively, there might be Birmingham clients who, say, work in London, so that, or a student in another city, so they might access a sexual health service in London, and in reverse, Birmingham will get charged by that authority back. So it all pretty much evens itself out. And correct me if I'm wrong, Juliet, those figures, the 80-10-10 split, have literally been the same since contract commencement, haven't they? It might vary slightly, but that is your ballpark figure, is that 80-10-10 split, which is largely in line with other areas.
Mm-hmm. Absolutely, yeah.
Thank you. I got a question myself. You've outlined a number of pathways for people to access services through the GP, online, or going to a clinic. I was looking at your sections on public health outcome frameworks for providing support for people who may be victims of sexual coercion, sexual violence, and sexual exploitation. And I'm suspecting here that those routes, the standard routes, may be difficult routes for them to feel able to use themselves. So how does that work with those particular categories of people?
Yeah, I'm happy to.
So certainly within the sexual health service, anyone who has any experience of sexual violence abuse, we screen for that when anyone attends, and we then have support services accessible within the clinic through our links with RSVP and with Women's Aid, and also with in-house support and in-house clinics. On our online booking service, which went down and it's going back up soon, people can directly book into what we call our Abuse Survivors Clinic, which is open to anyone who feels that they may have more difficulty accessing services because of what they've experienced in the past, to be confident that when they attend the service, they will be seen by someone who's fully versed and aware of the situation and able to provide that more tailored support to them. So there's direct access available for all those groups, and we actively screen people who attend the service to let them know that if there is anything that they wish to discuss with us, that there are those avenues of support available to them.
I think it's possible for people that may be in an exploitative position actually now, as opposed to in the past. Do you have any linkages with the police or other groups that people may be able to contact you through a third party, as it were?
So certainly the police are very well aware of our services. We have a particular part of the service called the SAFE Project, which works closely with sex workers and anyone working within the sex industry, and a number of they've actually been able to help out and work jointly with the police when talking about traffic situations and people who've been brought in through that. There are those links there that we kind of maintain and support.
And just to add to Meg's point, councillor Brown, there's also the sexual assault referral centre for the city. I think it's based in Walsall with satellites, where anyone that's been a victim of a sexual assault or crime, regardless of age, gets referred into by numerous routes. It could be by the police, it could be other emergency services, it could be by safeguarding, it could be by adult social care. And there's a direct link from that sexual assault referral centre straight back into Umbrella Clinic, where people will receive additional treatment, and then all the follow-on treatment is followed up in an umbrella setting. So those links are well established with the sexual assault referral centre, and that is where people would be at crisis, where they have been a victim of an assault. So those links already exist. Anything you want to add?
I was just going to say the other work we've done is with the Children's Trust and those organisations to actually build links between our health advising team, who are our point of contact often for the most vulnerable of our patients, with the people who support and work with them, to have a direct access referral route and an agreed referral system, such that important information that people may not want to repeat as they're passed from one system to the other is passed on and into us by the workers looking after them there, so that when they do attend the service, that actually we have that relevant information and that part of their journey is made as easy as possible.
And our colleagues in the Children's Trust are fully aware of all the pathways we've met. All those pathways have been shared, so they're fully aware if they come across someone where it might be a case of sexual assault, or even if it's treatment of STIs in a younger person, they know exactly how to refer. And we've got really good links between Umbrella and the Children's Trust, and adult social care as well, are aware of all those referral routes in as well.
Last point. They're not the victim of sexual coercion or coercive behaviour. If they refer themselves to that clinic, would they get their information given in terms of follow-up appointments and given to them verbally? Because I presume it could be potentially dangerous if it was they were written to, or information was passed through a text message.
We have very clear guidelines around communication with patients, and very clear guidance in our policy around domestic and sexual violence, that the most important thing when you're doing a referral for anyone is to make sure that you find out how they want to be contacted, what's the safe way for them to be contacted, and if there are any safe or unsafe times at which they can be contacted. We have embedded within Umbrella an independent domestic violence advocate who works with Birmingham Solihull Women's Aid, and also independent sexual violence advocates who are based within RSVP. And so they work within the clinic and will pick up people and discuss with them how they then want to be supported following that initial contact.
Yeah. And I think just one final, thanks mate, one final point to add to that. If Umbrella detect there's any safeguarding issues, say if a person's presented at Umbrella before anywhere else, then obviously all that will be raised by the safeguarding boards in Birmingham, so that person is picked up and other people are made aware. So it's a holistic approach. It's not just Umbrella working in isolation. There'll be links with adult social care, police if necessary, etc., through the safeguarding boards.
We've got about 5 minutes left in this particular session. Does any other members have any additional questions?
Can I thank you, members, for the questions, and can thank you for the presentation, which has been really, really valuable. So thank you very much.